I'm Lindsay Bennett, and I will be talking about increasing awareness of complex trauma in therapeutic practice. This is I actually just finished my dissertation like 2 weeks ago. So this is kind of chapter one of my study. So I'll talk a little bit more about what I did, but since it's not officially loaded and published, I could bring my whole study to present on. So we'll discuss complex trauma. I wanted to kind of have a little bit of discussion and then start with a definition or defining kind of exercise first. And then I'll talk about where we are right now in clinical practice, particularly in the American context with recognition of complex trauma, and then interventions that are most commonly used within this population, and what kind of measurements and things like that we have so far. I will talk then about how complex trauma is defined. I like to talk about the history of trauma theory first, because I think it positions everything well for how we started and where we are now in terms of complex trauma. And I think it can bring a little more of an uplift to progress being made, despite there still being some gaps. So trauma theory emerged with Freud's works back in the late 1800s, and originally he actually was studying complex trauma and experiences of abuse and things like intimate partner violence and childhood abuse and things like that within female populations, and was sort of working to further study and validate symptoms of what were labeled then as hysteria. There was a pivot in Freud's work, as most of us might know, where he kind of abandoned the validation of complex trauma and then moved more into his sexual development theories and psychoanalytic theory and things like that. Discussion of the reason for that pivot has been attributed to like political shifts in the climate in Vienna at the time. So some of that makes me sad, yes. Knowing the socio-political context makes me less vengeful of Freud. Maybe there's more to it. But so that's kind of where we were. And then trauma didn't really re-emerge until there was discussion of war, like post World War I, World War II, and some of the bigger wars. So trauma was really discussed within the context of veterans' experiences and not as much the complex piece. And we didn't really begin a re-emergence of this discussion until the 70s. So Judith Herman in America kind of was responsible for this resurgence of our conversations in the 70s. She applied the feminist lens to trauma theory and then reopened the conversation to complex trauma, all the childhood abuse, and continuous and relational. So she defines complex trauma as trauma that is continuous and relational, meaning that it's ongoing. It's not a single incident or a single, time point in your life. It's something that spans the test of time and is relational in nature most frequently. So like coercive control, emotional manipulation, things like that being involved, where there's a clear power imbalance between one person and another. So just some common examples: intimate partner violence, childhood abuse, of course, coercive control in any capacity. So the alignment here with this conference today, and things like human trafficking and all of that. So I wanted to talk a little bit about where we are currently. And again, I'm from America, I'm from Indiana. So within the American context, we're a little bit further behind some of the other parts of the world. But so CPTSD, or complex post-traumatic stress disorder, that was created to try and capture what can result with complex trauma. And this is recognized within the ICD-11, but not the DSM. So we use the DSM for diagnostics and billing and all of that good stuff in practice and for practitioners, but there is no capture of CPTSD. So there's a big gap there in being able to name symptoms that people experience and what we do with that information. So there's plenty of literature that supports CPTSD is a diagnosis and it is valid, and plenty of people experience this. There's just not the language and service delivery when it comes to the practitioners and things to be able to capture this. this leads to a lack of measurement tools for CPTSD. And this is, so what I did for the rest of my dissertation beyond chapter 1 was I developed a scale for CPTSD. There's another study yesterday that mentioned use of the ITQ, the International Trauma Questionnaire. That's kind of the one measure we have currently that captures the diagnostic criteria for CPTSD. But it was designed to be like a brief diagnostic tool. So it has just a few items to capture PTSD symptoms, and then a few items to capture the CPTSD symptoms. So the symptoms that come after PTSD that are a part of CPTSD. But it's missing like any physiological symptoms. So, it's very common to have battles with like chronic illness and autoimmune things and just increased heart rate and some of those physiological responses. Those aren't on the existing scale, as well as like conversation about systemic trauma as complex trauma. Like if you're a person who has experienced marginalized communities that experience trauma based on the systems that they live within, that is also seen as complex trauma, but not included in the scale. So that was the rest of my study. Maybe next year I can present the whole thing. This is just the beginning. So then when you have kind of the gap of the lack of awareness of CPTSD, you don't really have measurement to gauge what symptoms are and how we can improve them. We also have a lack of interventions that are available to be used within this population. And I know a lot of people presenting here today have talked about interventions and things that, are best practice for those who experience complex trauma. So it's exciting to hear of other people doing the work. I wanted to put this up here just for comparison. So this is the ICD-11 diagnostic criteria. On the left is post-traumatic stress disorder. So for someone to meet diagnostic criteria for PTSD, they are to have those 3 symptoms. Re-experiencing includes things like flashbacks, kind of uncontrollable intrusive thoughts, vivid memories, and that these intrusive experiences cause like physiological distress or some sort of like triggered or activated response. The second is avoidance of reminders. So maybe you went through something specific and traumatic, and so you might avoid that place where that incidents took place, or people that remind you of the trauma or things like that. So avoiding things that you wouldn't have before. And then persistent perceptions of threat or hypervigilance, so kind of always feeling an increased level of anxiety and some of the physiological responses there. So that's just PTSD. Another distinction here in the DSM, PTSD also includes a 4th domain, alteration in cognition and mood. So if you're someone who experiences more like depressive symptoms or reactive emotions or things like that, that's included in the DSM. So then for CPTSD, to meet diagnostic criteria, you are to meet all symptoms of PTSD plus the problems listed on the right. So problems in affect regulation, like trouble managing or regulating emotions, that being both like your external expression of emotions, how you communicate that with others, as well as your internal experiences of your emotions, maybe feeling misaligned. Persistent beliefs about yourself, and that kind of changes in self-concept, goes beyond what we might think of as like self-esteem or just your overall self-worth, and gets into the deeper like relationship that you have with yourself and how you perceive yourself in the world, connecting with others. And the third for CPTSD is difficulty in sustaining interpersonal relationships. So whether that be trouble in maintaining boundaries to have healthy relationships, or just kind of inconsistency in relationships. So all of those being unique to CPTSD. So I'll shift to talk a little bit about interventions that are currently researched and supported for CPTSD. My area of research is more focused on somatic interventions, like the embodied healing. Yoga being an example, weightlifting is a newer one with some pretty promising results. There are some big studies out of the Center for Trauma and Embodiment in Boston, Massachusetts. They have a weightlifting program that they just were able to do a control trial on, and it had some really cool findings, particularly with men, like where some of the other somatic interventions may not be as popular. This one was and had some pretty promising results. And yeah, the Center for Trauma and Embodiment, so it's CFTE. They're in Brookline, Massachusetts. I think if you look it up on the website, it'll take you to the Justice Resource Institute, and they're out of that larger research center. But the thread between all somatic interventions is sort of how it interacts with your brain and what you're able to do when you're moving your body neurochemically or neurophysiologically. And with yoga and dance specifically, the weightlifting is still new, so there's not as much research that I'm familiar with on that one, but the common thread is that you're sort of able to move through the same neural pathways that you move through when you're experiencing emotions, but in a safer context. And so with any of these, you would want the relationship with the facilitator to be a safe space. So you need to take the time to build a safe relationship and all of that first before engaging in any type of embodied approach, just to be able to facilitate healing, of course. And oftentimes these are used as adjunctive treatments to like talk therapy. So you kind of have both pieces of being able to have the physiological component as well as able to cognitively talk through emotional processing and things like that. There is plenty of research where these interventions are used as group modalities, where you just kind of come and you do the yoga group or the dance group or what have you. But there has been some differences between that type of research and if you're able to do something like this independently with a facilitator, and kind of the implications there are that there might be a deeper healing that occurs rather than just doing the physical intervention in a group concept or in a group context. And I have cognitive approaches listed, but again, my area of research and where I'm more passionate is in the embodied approaches, but trauma-focused cognitive behavioral therapy being one, cognitive processing therapy and EMDR. Though within the context of complex trauma, EMDR has been studied to be not as effective. Like EMDR is more effective typically if you're able to process like a single trauma, a single traumatic event. And if things are more complex or you have these more nuanced kind of challenges that you're facing, then EMDR hasn't been quite as effective.
The yoga, weightlifting, dance, is that just a person just attending those groups? They don't need to have any kind of guidance or facilitation?
No, there's
just go along to a dance class.
No, there should still be facilitation for it to be a therapeutic approach. Yeah, some sort of facilitation with like a trained provider. Yeah. So also out of the Center for Trauma and Embodiment, there's a yoga program that they train therapists to be certified in trauma sensitive yoga, and there are.
I was gonna say, what's the difference there? Is it just like, it feels like there's just a lot more intentionality around movement with
like the purpose of the intervention, and I think too there's a lot of room sometimes within the yoga community, particularly that's where I spend most of my time. If you were to just go to a yoga class or be involved with a yoga studio, there's no guarantee that it would be trauma informed. And particularly in the West, when you have Western yoga, it's often used for like exercise and just to go. And so that's a very different purpose than trying to navigate through deeper traumatic experiences and like build that connection with your inner self. Same with dance. the relationship with the teacher, if you were to go to just a regular dance class of some kind, would be very different than if you were to go to a catered, sort of more intentional place where there was a trauma-informed approach happening.
They always do it in groups, or is it one-on-one?
Yeah, sometimes one-on-one, like the trauma sensitive yoga out of the Center for Trauma and Embodiment, that's a one-on-one approach. It's been tested in groups, but if you go through the training and things like that, the intention is to be able to use it in a one-on-one, therapist to client or facilitator to client. To be able to really have like conversation with each movement, like what are you checking in continuously? What are you feeling in your body? What kind of response are you noticing and things like that, so that you can have the communication happening with the movement rather than just moving through the movement. Then I wanted to talk about intervention, or not intervention, scales that we have currently within CPTSD. Again, this being a piece of my dissertation that is preliminary, so I can't talk about what I did fully, but I just wanted to highlight the gaps really here. So these 3 bullet points represent 3 different studies that were focused on measuring like how effective an intervention was for people with complex post-traumatic stress disorder and the scales that they used. So as you can see, particularly in the first and third one, they had to use a lot. They had to use a lot of scales to be able to capture all of the symptoms present with CPTSD. So in this first one, the first and third scale, so the CAP-CA, that's a trauma PTSD self-report scale, and this study was for children and adolescents, so this is the version for children and adolescents. And then another CPTSD scale down here at the bottom, or the third version. So if we remember the differences between PTSD and CPTSD, if you have a scale that's intended to just measure PTSD, then you're missing the other 3 symptom clusters that are important for CPTSD. So what this study did was included the borderline symptom list as a third scale to try and capture the remaining symptoms that are present in CPTSD. I personally am not a huge fan of personality disorders in general, but particularly borderline personality disorder, if the appropriate lens is trauma, if symptoms are present because of traumatic experiences, then the language is going to be different in how you are measuring the symptoms, and the lens in which you are viewing symptoms being present in the first place is different. So the language used on this scale is much more focused around like just an individual's challenges in managing emotions and core boundaries and things like that, which I just don't think does justice to all that is in CPTSD. The second was a study that was again focused on children and adolescents, and they were measuring a cognitive therapeutic approach and how well it worked for kids who had experienced long-time childhood abuse. And they only used a trauma scale, so it was a bit shorter, easier for kids to complete, or adolescents to complete, because they didn't have to worry about filling out, 3 different scales, but there were quite a few things missing in terms of symptoms. And then the last one, again, you have kind of just like a melting pot of scales being used and all of the things. This one does, so the adverse childhood experiences, that one would capture types of complex trauma, but only those experienced in childhood. So if you entered into any kind of ongoing harmful relationship in adulthood, that's kind of being missed there. And they do have more with the emotion regulation piece on this one, but we're missing like the interpersonal components and challenges there. So again, this just to highlight where we are, what's being used in literature when you're trying to study an intervention and how effective it is for CPTSD. And I like to think about what would I feel like if I was in the participants' shoes, trying to move through a study and help bodies of research and things like that. And I would be very tired if I have to fill out 4 scales and trying to complete a research study. And then from the researcher side, if you're trying to match up what symptoms are impacted where and things like that, that's a lot to keep track of, and maybe some overlap, and how do you code all that? I don't even know. So there are problems, there are gaps. So again, what I think we should do in practice, and part of what I did, I think as clinicians, we have or clinicians, layperson, you know, wherever you are within the community of complex trauma and what that means for you, I think there's a responsibility to continue the awareness of CPTSD and how we discuss that within our professional spheres, whether that be in practice or otherwise. There is an increased awareness for what interventions work best for what populations. I think there's a lot of nuance to that. I mean, I think we need to meet individuals where they are as well. So not every intervention, of course, is going to be appropriate for all people with CPTSD, but just being able to have support for multiple things so that we have kind of more of an array to choose from when it comes to what our interventions look like. I should also say with that, I'm a therapist within private practice. So when I talk about the gaps and things like that, I'm more talking about how we approach like standardized mental health care. I think in private practice, you have some freedom to be able to kind of do what you think is appropriate and what fits your populations and your clients best. But when it comes to standardized care and what other like insurance and healthcare companies, I know that's also not a problem everywhere, but it certainly is where I'm from. What they kind of allow as your modality is pretty narrow. And I think we need more measures for CPTSD. So like I said, my full dissertation was developing a scale for CPTSD, and I was able to include several items. So the full ITQ has 12 items, 6 for PTSD, 6 for CPTSD. And the final version of the one I created had 37. So there were more items for each symptom, as well as inclusion of like the physiological responses and things like chronic illness and trouble with sleep, things like that. So that was just more robust. I did use the ITQ as the foundation for my scale, so it's an expansion of what has kind of already been done. And then I think it's also important to acknowledge that if we are treating CPTSD, a lot of that is reactive, so that's kind of a separate body of research, but I just think it's also important to note that there can be preventative work done within this field to help set people up for success, to feel more empowered and, you know, when it comes to things like childhood abuse, supporting parents and things like that, so that certain types of complex trauma can decrease in prevalence in the first place would be my pipeline. I think that's about all I have. Again, this is chapter 1, so rest to come hopefully next year and beyond. I have my references if anyone's interested. It's just a few, and I'd like to open it up for questions, comments, or any discussion.